Hi guys, Dr. Dillard here. Let's finish up UC, ulcerative colitis. It is week 10, it's Thursday, it's the spring of 2021. And where have we been? Well, we talked about ulcerative colitis last time. It is one of the inflammatory bowel diseases. The other, its kind of brother, is Crohn's disease. Classic symptoms of ulcerative colitis is diarrhea. That's probably the number one sign. It often is bloody diarrhea, so you get hematokesia. Often have abdominal pain with the diarrhea and cramping. And we'll look at all the symptoms in a little bit. But this one, unlike Crohn's disease, it only affects the rectum and the large intestine. And there's no skip lesions. It'll start in the rectum and work its way up into the sigmoid colon and descending colon, transverse colon, and etc. It only rarely gets into the, if ever, super rarely it could get into the intestine, but for our purposes it's small bowel. For our purposes it's always in the large bowel, affects the large bowel. Also, unlike Crohn's disease, UC infects only usually 90% of the time or so, it affects only the mucosal layer, or Crohn's disease affects the entire bowel wall. Like Crohn's disease, it also has extraintestinal manifestations, but they're not as frequent compared to Crohn's disease. But unlike Crohn's disease, this one can get so bad that you have to cut out the diseased colon. In fact, over lifetime, about 30% will need a colonectomy to remove the diseased and bleeding colon. Clinical features: the onset is typically slow and is often misdiagnosed with maybe Crohn's disease or irritable bowel syndrome. On average, it takes about 9 months before you get histological sampling to make the diagnosis, and there is no single test. It's kind of made with biopsy findings and symptoms, and so it's not maybe some autoantibody findings. So it's a difficult one to pin down. It can also present in other ways with different symptoms. Here's a more comprehensive symptom list. So diarrhea is always at the top. It's often a bloody diarrhea, but doesn't have to be. Abdominal pain, sometimes so severe you're headed for the emergency room. It is one of the causes of acute abdomen. You can have rectal bleeding without the diarrhea. Hematokesia, it's usually fairly red in color. You can get a lot of mucus coming out of the anus mixed in with the fecal material as well. Tenesmus is also a common finding with this, the feeling that you have to defecate and you can't. You sit on the toilet for an hour and you push and push and nothing comes out. It's because you really don't have to go, you just feel like you have to go. And when you really do have to go, there's a sense of urgency and you can have some fetal incontinence. So those are pretty much most of the normal symptoms. Severe symptoms, you can have fever from a severe attack of this, and some lab findings. You can have anemia from the frequent bleeding and dehydration from the chronic diarrhea. And the diarrhea can be, as we said, often accompanied with blood, even large quantities of blood and pus and mucus. In Crohn's disease, we didn't talk about bleeding, did we? That doesn't happen that often with Crohn's disease, so that's one good difference between them, clinically speaking. So yeah, hematokesia, that's bleeding from the rectum, either mixed in with the fecal material or on its own, hematokesia, and that's a reddish colored blood. It's not black tarry blood. That's a common finding. What causes the diarrhea? Well, it's the inflammation affects the colonocytes. Remember the epithelial layer of the colon, the colonocytes. One of their jobs is to reabsorb water. And if they're inflamed, they're not going to absorb salt or water. So that passes right on through as the stool. Laboratory findings. For people who are in remission or have very mild disease, the laboratory findings may be completely normal. People with the more severe diseases, there is a marker, a protein that's released, and then that inflamed intestine releases. That's called a fecal caprotenin, captoprenin protenican, captoprotectin, tectin. That's it. I just found this today. I didn't know about this. This is new for me too. Fecal calprotectin. It's almost like protectin, isn't it? Protectin, calprotectin. Schlesinger says the sensitivity and specificity is in the 70s, which isn't too. It's not great, but it's not too bad. And yeah, that's a marker for intestinal inflammation. That can be positive in ulcerative colitis as well, not just Crohn's disease. The severe diseases we just said, anemias may be present, leukocytosis, lots of white blood cells because of the infection, thrombocytosis. These are all inflammatory markers, and ESR and C-reactive protein levels could be high because of the inflammation. What is the etiology and pathogenesis of ulcerative colitis? We really don't completely understand it. It's just like Crohn's disease. We know it's an inflammation of the intestine, but we don't know what drives the inflammation. Like Crohn's disease, there are three kind of camps or factors on theory: gene mutations, host immunity, environmental factors. Many of them are the same as for ulcerative colitis, but I'm just going to pick on a few of them here. Genetics. Schlesinger believes this is a very strong risk factor, like if you have a first-degree relative, mom, dad, brother, sister, grandparents. If one of them has Crohn's disease, your chances are much greater. 15% of families have more than one Crohn's member affected, so kind of lends support to that theory. Monozygotic twins carry about 11% chance concordance rate, so that's not the greatest number in the world, but it's better. It's higher than the average person walking down the street. So there's definitely a genetic history. Took almost all these slides out because they just don't know. This could change in 5 to 10 years. But there are 23 genes that are discovered that are related to ulcerative colitis on chromosomes. All those chromosomes. I'm not going to ask you which chromosomes unless we talk about them specifically. So there are a couple we need to talk about. And these are bug-catching receptors. So on APC cells, like monocytes, macrophage, dendritic cells, the bug-eating cells, really important to guard the right beneath the mucosal layer. They live underneath the epithelium, and their job, and they live in the submucosa as well. Their job is to eat bugs that have gotten through the tight junctions of the mucosal layer of the epithelial cells. And they bugs bind to these receptors that are on top of these APC cells. So they're very important. If you have mutations in the genes that make the bug binding receptors, I'll call them, you can't bind the bugs, and the bugs walk right by and get deeper and deeper and start breeding and growing and growing. And so there's two that are well talked about in the literature. There's an interleukin 23R gene, or IL-23R gene, which is on chromosome 1. And there's the interleukin 12 beta gene, which is on chromosome 5. And they both do the same thing. They encode for, which means through the central dogma, they make receptors, bug-catching receptors. And they're broken. They don't catch the bugs. I mean, what kind of deal is that? That's no good. And without the bug-catching receptors, the APC cells are handicapped, and the bacterial infection can get out of control. In fact, even commensal, like the good bugs, can get in where normally they wouldn't be killed immediately. They can get in and multiply and cause spark and inflammation. Once they multiply enough, body's immune system spots it, and here comes the invasion. Here comes the wicked inflammation that ends up destroying the bugs, but it destroys good tissue as well. So not good to have those receptors out of action. Another cause, autoimmune disease. So there's another strong belief that autoimmune factors are involved. And in fact, it took most of it. We were getting too far into the weeds on that. I took most of those slides out. But there are antigens that are associated with this. And the same story, for whatever reason, some phenotype changes in the colonocytes. So some dormant gene gets turned on, and the colonocytes look a little different. And the body's immune system looks at them and goes, I used to know who you are. I'm not supposed to attack you, but now you look foreign to me, and it attacks them. And that's classic autoimmune disease, right? And what supports the autoimmune theory is people with ulcerative colitis do have a lot of concomitant autoimmune diseases like thyroid, Hashimoto's disease, diabetes mellitus type 1, pernicious anemia, type A, the type that these are all autoimmune related. So there is probably an autoimmune category to this thing. One autoantibody I want to talk about in particular is the Pianka I call it, the Pianka autoantibody. A little bit over 50% of people who come down with ulcerative colitis, when they get tested, they'll test positive for this gene. So that's a pretty big number. It's a member of IgG sub1 subclass, and it's interesting because it doesn't attack proteins on the cell membrane of an enterocyte. It actually attacks the DNA, which is very strange. I don't know if you've ever heard of an autoimmune attack against histone proteins, right? We all know histone proteins, the DNA, the chromatin wraps around the histone proteins. It helps it organize it when it's headed for metaphase. So yeah, it's an autoimmune attack against histone proteins, and the inflammation is too wicked, and it spreads and causes an inflammation, and all the sequelae that go with inflammation. Enterocytes stop absorbing water, and you get diarrhea. They start stimulating pain receptors, which causes stomach pain, all kinds of stuff. So Pianka serves as an important marker also to predict the severity of the disease. People with Pianka antibody tend to have the colon removed, the colectomy, much more commonly than people without this. So it's an interesting gene. That's all we'll say about it. Where does it strike? About 45% of the cases, it hits the rectum and the sigmoid colon only. They still include that as the colon. Even the rectum, they still include that as part of the colon. But in almost half, it never gets out of the sigmoid colon. And then, of course, it can spread kind of upstream into the descending colon, the transverse colon. About 10% of those affected have a pancolitis. This is a little different twist on the word pan. Let me get some water here. Usually pan, we talked about a pan inflammation where it was a full thickness, like in ulcerative or like in Crohn's disease. This time they use the word pan to mean that the rectum, sigmoid colon, ascending colon, transverse colon, descending colon, everything's affected. And that's a pancolitis. And that's a bad, dangerous one. That's also has another name called fulfillment colitis. Make note cards of those two. Pancolitis, fulfillment colitis, dangerous, 10%. No skip lesions still. It still follows that rule. But we'll talk a little bit more about that. That fulfillment colitis, we'll see a horribly affected intestine by that. Often end up in surgery. What's the endoscopic appearance? What do they look like? Remember in Crohn's disease we had cobblestones. We had amphus ulcers. You still get the amphus ulcers in ulcerative colitis. One of the first things that happens in ulcerative colitis is you lose the normal vascular pattern of the colon. I'll show you a picture of a normal one and what I mean by that in a minute. And then it becomes red as the inflammation starts, and then ulcers can form and they can bleed. So aphthous ulcers form, and they erode into the submucosa and it can start bleeding. Here's a normal vascular pattern of a large intestine here, sigmoid colon. Even the proximal part of the rectum would look like that. Here's someone with early Crohn's disease, and you can see all those vascular patterns are gone, right? There's the vascular patterns. Now they're gone. So lots of little petechiae hemorrhage here, and that would be oozing and dripping blood. So the patient would have a bloody diarrhea with this. It's going to get worse though. With the passage of time, you don't, and make a note card of this, you don't get cobblestoning, no cobblestones with this condition. They look like cobblestones, but they're bigger and they're not as uniformed, like a cobblestone road in Crohn's disease. It doesn't look like that. They're a little more spaced out, and there's huge ulcers, aphthous ulcers, between the cobblestones oftentimes. So here's what I mean. So kind of looks like cobblestones, but they're way too spaced out. If you go back and look at the Crohn's disease notes, it looks way worse. And you have huge ulcers. Look at that white is all one ulcer. An ulcer here, an ulcer here. So you can imagine this is incredibly painful. So those are pseudopolyps. Making the diagnosis difficult. There's no single test to make the diagnosis. You have to use all the things I've just talked about to make the diagnosis. All right. What's the hallmark of colonoscopic findings? Well, we just talked about those. So you get an inflammation. You lose the normal vasculature of the colon. That's replaced by that little redness and sometimes petechiae hemorrhage. Signs of inflammation is erythema or redness. And yep, loss of that vascular pattern. So the vascular pattern is gone in this patient with Crohn's disease. You don't see that vascular pattern, but you see redness all over the place. It hasn't progressed into ulcers yet, but this is a ulcerative colitis patient. What about differential diagnosis? Well, the number one finding is diarrhea. So there are other diseases that cause diarrhea, like maybe it's a chronic bacterial infection, a gastroenteritis type thing. Maybe it's a parasite that's gotten in there. It's E. coli that's overpopulated, chlamydia, gonococcus, all sorts of opportunistic bad bugs can get in there and do this as well. Those all have to be ruled out. Can you see this on radiograph? If it's severe disease, there are some classic findings, and I'm sure the DAC bars will get into this further. But just to whet your appetite, there's two classic radiographic findings of ulcerative colitis. One is called thumbprinting, where the intestine, the affected intestine, is just thick with swelling and inflammation, and you can see that on a soft tissue abdominal film. Thumbprinting is the hostrations get super thick, and they can get so thick that you don't even see the hostrations anymore. It just looks like a lead pipe. So that's severe ulcerative colitis. So here is a chest, or here's an abdominal film. This looks like a regular, just a regular lumbar film. But look at the transverse colon coming across. Look at these gigantic fingers coming down. Those are hostrations, right? You never see that on X-ray. I don't know if you've looked at it enough to know that or not. And it's headed toward a lead pipe, because look how thick the intestinal wall is getting here. And with the passage of time, it can convert into this thing. So there's kind of a lead pipe finding in someone. So, no good. Some fun facts: about 25% of patients with ulcerative colitis will need surgery at some point. Some say 30, some say 25. Somewhere around there, a quarter of them. The severity of the symptoms is typically related to the severity of the disease. So if you go into the ER with acute abdomen, horrible pain, it's ulcerative colitis, the chances are it's fulfillment colitis, and you're going to be at high risk for having your colon removed. What about smoking? We've talked about this before. Heavy smoking, strangely, is protective against ulcerative colitis, which is very strange. And paradoxically, light smokers have a higher chance of developing ulcerative colitis. And that's proven by nicotine therapy. Heavy nicotine therapy seems to be somewhat protective against ulcerative colitis. There is a danger, though, when heavy smokers stop smoking and quit, they're at super high risk for ulcerative colitis. So smoking and ulcerative colitis have some weird associations. Another one, this is kind of the opposite. Remember, we said, I think I said in Crohn's disease, if you've had an appendectomy, it greatly increases the chances of you getting Crohn's disease. Well, it's the opposite for here. If you've had a prior appendectomy, it decreases the chance of developing ulcerative colitis, which is strange, and we don't know the mechanism. So there's some theories about removal of the lymphoid tissue in the appendix. Maybe somehow alters the microbiota, but they don't know. But the facts are, you should know the facts. Appendectomy, that decreases the chances of UC, but it increases the chances of Crohn's disease. When do you need a surgery? Well, there's kind of two broad camps. There's emergency surgery, and you kind of need it, you kind of don't. It's up to you. Of course, emergent surgery occurs with acute fulfillment colitis. When the whole colon is so swollen, it starts bursting and leaking pus into the peritoneal cavity, and you can get a massive peritonitis, which can quickly jump into a septicemia and kill you. All kinds of toxins are released. It's called toxic megacolon. I'll show you that in a second. Colonic perforation is what occurs, and colonic hemorrhage occurs in these huge fulfillment colitises. So if the colon gets huge, it has to be removed because it also stops working. Now, kind of on the fence surgery are people who just have either cancer or dysplasia. I mean, if it's malignant, it's got to come out. But dysplasia, you can take it out or not take it out and just watch it. Probably would take it out if it was me. Severe extraintestinal manifestations. There is some research that shows if you remove the diseased part of the colon, it stops the knee destruction or the SI joint destruction. Remember we talked about how that kind of that enteric arthropathy occurs in this condition where we don't quite understand it, but the leading theory is the diseased colon is being broken down by the inflammation process, and chunks of it are getting into the microcirculation. Chunks of dead colon tissue get into the microcirculation, they float around and they get stuck. And then the body thinks that's part of the Crohn's disease and attacks, and they get stuck in the knees and ankles and SI joints. So if you remove the source of that dead tissue, which is the colon, then it stops the destruction of the joint. All right, I promise we'll talk about fulfillment. About 10% of people have this again. It's terrible. It involves the entire colon for one. It also involves the entire full thickness of the wall. It doesn't stay isolated in fulfillment ulcerative colitis. It's not just the mucosal layer. It's the entire wall of the intestine. The submucosa and the muscularis externa and the mucosal layer are all inflamed, and the intestine swells and swells and swells, and it gets horrible looking. And it is a life-threatening condition because it's typically seeping pus and leaking and bleeding into the peritoneal cavity, and that can kill you through peritonitis. And and once it gets so big, it stops working. You can't have peristalsis, and then you got yourself an intestinal obstruction, which is a medical emergency. When peristalsis stops and the intestine is greatly enlarged, it's called a toxic megacolon. Toxic megacolon. That happens in about 3% of patients with ulcerative colitis. Should have warned you, but there is, believe it or not, that was taken out of somebody. And that's pretty much the The ascending, transverse, descending, and sigmoid colon was taken out. And you can see how the inflammation has just gotten ridiculously crazy. That's not a fake. That's not a Photoshop. That's real. Urgent surgical removal is the treatment for fulfillment colitis, period, end of statement. You'll die if you monkey around with that, trying herbs or whatever you want to try. It's got to be removed, colonectomy. And how do they fix that? Well, if part of the rectum or the rectal canal is still not affected, you can attach the ileum right to the rectal canal and just bypass it, and you can still live just fine like that. What about the treatment for this? I'm not going crazy into the weeds on this. It's an uncurable disease. There's no cure for it. The goal is to get the patient into remission and keep them in remission as long as possible. You want to make sure nutrition is on board, because they're not going to be eating, and the diarrhea means they're losing all kinds of vitamins and minerals and such. And try to get it in remission and keep it in remission, and this medication has to be used. What's the medication? The 5-aminosalicylates are the #1 treatment for mild disease and moderate. The patients that I have known who've had ulcerative colitis, this is what they've been on. They need runs with the glucocorticoids for flare-ups, which will help. If it gets severe or moderate to severe, infliximab or Humira, tumor necrosis factor alpha anti-inhibitors, anti-tumor necrosis factor alpha medication will do the trick. That has side effects. I had a patient a couple of weeks ago who had bad side effects from that. It was wrecking the liver. They had to stop those. So they're really tough on the liver. IV glucocorticoids, not just oral prednisone, and cyclosporin for any infections that pop up. All right, maintenance therapy is the same, usually 5-aminosalicylates, infliximab, if it gets stubborn. Okay, let's talk about Hirschsprung's disease. It's still 2021. It's spring. It's the last lecture for GIGU. It's Thursday. So remember neural crest cells. You're like, oh no, it's embryology. Yes. Remember the neural crest cells. So when the neural plate was folding down to form the tube, these lateral regions of the neural plate morphed into a special mesenchymal type of cell called a neural crest cell. These cells are really, really important for forming nerves, and especially the ganglion of nerves. So that's important to remember. We didn't get into this in embryology, but they swim. They're mesenchymal. They can move. They swim to every nook and cranny of the body to make nerves and ganglia of nerves, including the enteric nervous system. So if something goes wrong with that formation of the ganglia of the enteric nervous system, you have Hirschsprung's disease. So let's get into it. Hirschsprung's, called HSCR oftentimes, congenital agangliosis, congenital megacolon, intestinal agangliosis. It is a congenital disease, so kids are born with this. And it's basically a region of the colon, usually the rectum and the sigmoid colon is typically affected, where peristalsis doesn't work. And the reason it doesn't work is because neural crest cells were not able to migrate into the area and form the ganglia cells of the myenteric plexus, Miser's plexus, and Auerbach's plexus. Those are the two plexuses of the enteric nervous system of the gut wall, which we've talked about a lot. So basically no peristalsis. It's typically caught about 90% of the time. It's caught within the first year of life. 9% early in childhood it's diagnosed. Only 1% of this, 9% of people are diagnosed in adulthood. They're caught much earlier usually. Right, and remember there's our plexuses. There's Meissner's plexus. There's Auerbach's plexus, just to kind of bring back. So this is the enteric nervous system, and this is are responsible for smooth muscle. Remember, Arbox plexus causes contraction, peristaltic contractions of the smooth muscle here, and our Meissner's plexus causes contraction of the mucosal layer. There's a muscular layer there as well. So, again, thought to occur secondary to the failure of neural crest cells to migrate into the intestinal wall, and therefore no neural ganglia are formed, and therefore it's basically a broken system. Therefore, the affected intestine cannot undergo peristalsis, which is basically a small bowel obstruction, right? And there's varying degrees of it. It can be complete obstruction. If the child is born and there's a complete obstruction, you're going to find out really fast. Maybe it's an incomplete, and the child could go for many months or many years before they figure out what it is. Again, most commonly affects the rectum and sigmoid colon. And but in unlucky people, it could infect the entire colon. The initial signs of it. So when a baby is first born, we've talked about the meconium before, how the meconium needs to be passed. That's the first fecal material. If the infant fails to pass the meconium within the first 48 hours, you always think it's Hirschsprung's disease versus cystic fibrosis. And just a note, there's no stars on these slides because this is brand new stuff. So this stuff, all of these slides are fair game, just as much as where there's stars on them. So don't let the no stars think that you don't have to study this. So one of the initial signs is abdominal distension as the fecal material backs up and the colon gets bigger and bigger and bigger. It can get 5, 6, 7 times as big as normal. It can get huge. And the child's going to have abdominal tenderness and be crying in distress. They may be constipated because very little fecal material is getting through. They may be obstipated, meaning no fecal material is getting through. So here's a cartoon of a sick child, and if you look inside their abdomen, the colon is gigantic. Where's the obstruction? The obstruction is right down here. That's where the peristalsis doesn't work, and it's like a beaver dam, right, which you've talked about a million times. All right, there's some bad stuff that can happen. So if in the backup, the upstream of the beaver dam, bacteria are loving it because they're breeding and growing it to the point where they invade the intestinal wall and cause an inflammation. And the inflammation can be dangerous. It causes swelling of the intestinal wall. It can cut off the blood flow. The swelling can compress arteries, and the tissue can become ischemic and rupture. And so you can get peritonitis, bleeding and peritonitis with this condition. This is one of the causes of acute abdomen. The patient would have so much pain that they will be in the ER. They can't stand it. And of course, peritonitis can lead to septicemia. All right, just 34. So a pretty big number, about 35%, will get an inflammatory response. And what is that inflammatory response called when it's secondary to Hirschsprung's beaver dam? If the intestine gets inflamed upstream, that's called an enterocolitis. Enterocolitis. Right? What are the symptoms of Hirschsprung's disease, especially if it's enterocolitis, colitis that has occurred? Well, if they have a wicked inflammation, some of the inflammatory molecules are going to be triggering fever, so you'll have a fever. You'll have explosive diarrhea from all the gas that the bacteria are causing. You have a buildup of bacteria. They're causing tons of gas. The gas is also stretching out the intestine, so explosive diarrhea. If it backs all the way up into the stomach, you can start throwing up. Bile can start being pushed into your stomach. And we said bile is very irritative to the stomach, and you can throw up, and you can have bilious eminence. So eminence or bilious eminence is associated with a long backup. And then you don't feel, if you have fever, you're sick. You have lethargy. and it can again lead to peritonitis and septicemia. Here's an 8-year-old female who has battled lower abdominal pain, not in this country, for a long time. Finally got a GI study was done, and you can see the problem, megacolon, right? But here, this is not a little piece of, well, it could be, but remember when the colon is affected, remember Hirschsprung's disease likes the rectum and the sigmoid colon, and this is the sigmoid colon. Maybe a little bit of the descending colon is affected. This is aperistalsis. In fact, it looks like the rectum is actually working here because that looks full. So it looks like the problem is the sigmoid colon solely in this patient. Maybe a little bit of the the proximal part of the distal part of the descending colon. All right, obvious megablast in this patient, right? Everything or not megablast, obvious megacolon in this patient. You can see it's blown up like crazy. Everything I explained already. Epidemiology. So how often does this occur? According to Robbins, about 0.02% of newborns have this. So it's twice as common as Marfan syndrome is 0.01%. Let's see. Kids who are born with Down syndrome have a much higher prevalence of Hirschsprung's disease. We don't know what the connection is, but there's a definite connection. So if the kid has Down syndrome, there's actually a 10% chance that they also have Hirschsprung's disease. There is a genetic connection with this disease as well. If one sibling has it, there's about a 4% chance the other sibling will have it. So there's a genetic connection. Females tend to be more severely affected than males. How do you make the diagnosis? Well, you have to go in there and get a biopsy. Once you get a biopsy and take and look at that under the microscope, look at the Meissner's plexus and Auerbach's plexus, you'll see there's missing nerves. The neuroganglia cells are basically gone. So it's quite easy to make the diagnosis once you have a endoscopic specimen or a histological specimen to look at. What is the pathophysiology? It's the neural crust cells. They don't migrate into the wall of the sigmoid colon or wherever the area is, and they don't form an enteric nervous system. There's no way to fix that. So there is a gene that they talk about. There's a couple genes, but there's one that sticks out above the others. So it's a loss of function mutation, meaning the mutated gene doesn't work. And the gene's name is kind of strange. It's RET, R-E-T, receptor tyrosine kinase gene. RET receptor tyrosine kinase gene. So rearranged, RET stands for rearranged during transfection. There's other ones, but we won't worry about that. But you should know this mutation definitely increases the chance of having the diagnosis of Hirschsprung's disease. What's the treatment? The only treatment, if it's severe enough, is surgical resection. You have to take the dead colon out and then tie off the ends that are still functioning. Sometimes you have to take the rectum out and the sigmoid colon and part of the colon out. But if you still attach the colon down to the rectal canal that's not affected, you can still work. You can still have a functioning GI system. All right. Just a note, it's a big surgery, and it can take years for normal bowel function to return. It's a long struggle with this condition. Here is a patient who suffered Hirschsprung's disease until the teenage years. And this is not a Photoshop. This is the size of the patient's colon. So it's huge, all stretched out from fecal material, from gas. It just stretches and stretches and stretches, and that's what you get. Acquired megacolon. So there is a way to get a colon. That's a megacolon. I mean, without knowing histological sample, you can't tell that apart from the fulfillment colitis of ulcerative colitis versus Hirschsprung's disease versus an acquired megacolon. So you need to know something about the histology. So the most common cause of acquired megacolon is Chagas disease. Remember, that's caused by the Trypanosoma cruzi bacteria, which invades and destroys the walls of Auerbach's and Meissner's plexus. That's the only other condition that really can destroy ganglion cells. Remember, and that's called Chagas disease. Remember, this bug loves, for whatever reason, it loves ganglia cells, and it can get in and destroy those ganglia cells. That's a high yield question right there. So this is not congenital. I can see the question coming now. I can try to trick you and say Chagas disease is congenital, could cause congenital megacolon. It can't, because this happens after birth. The child has to be infected by this trypanosoma. Am I saying that right? Trypanosoma cruzi virus. So make sure you know. I'll make a note card of that. Acquired megacolon from inflammatory conditions can also block. It can block regions of the colon, of course. So in other words, there's other things besides Chagas disease that can cause acquired megacolon, like inflammatory conditions such as cancer. Ulcerative colitis can cause, we saw an example, fulfillment colitis is an acquired megacolon from ulcerative colitis. Toxic megacolon, visceral myopathy, psychosomatic disorders. So there's other things that can cause this we're not going to get into. All right, let's look just a little bit at appendicitis. I don't know how far I'm going to get on it. My voice is kind of recovering, but it's still a little shaky. And we talked about this in lab quite a bit. So appendicitis also is an inflammation of the appendix. Veriform appendix is not. Or I see what I was trying to do. Veriform appendicitis. Veriform appendix is an AK for the appendix. That's the full name for it. It's been around forever. Back in Leonardo da Vinci's days in the 15th century. That's a Mona Lisa, of course. The first appendectomy was done way back in 1736 on an 11-year-old boy. So it's been around for a long time. The word appendicitis was not created until 1886. I would never ask you a question about that, other than it's been around for a long time. It is simply a painful inflammation of the appendix, as the word says. It is one of the causes of acute abdomen, which we've talked about, considered a medical emergency, especially when the inflammatory process eats a hole through the wall of the appendix and all that pus and inflammatory juice drain out into the peritoneal cavity, and that causes an inflammation and septicemia. And what's the solution? Appendectomy. You got to take it out. What's the epidemiology for appendicitis? Well, it's the most common acute abdominal emergency in developed nations. Is the most common surgical condition for both children and adults. The annual incidence is thought to be about 0.1%, so it's much more common than Marfan syndrome. Interestingly, the incidence is 10 times lower in parts of Africa, so there seems to be a kind of a genetic risk that some races have over other races. The most risky time, and the patients I've known and the students, I've had quite a few students, 3 quarters in a row I had someone had an appendectomy. The most risky time is between the age of 15 and 19. Lifetime risk is about 12% for males and 23% for females. So that was the annual incidence. I just thought that's really low, but that's per year. About 0.1% of the population will have this per year. The lifetime risk is much higher, 12% for males, almost double, 23% for females. So it's more of a female problem. Perforation is not a good thing because it can lead to peritonitis, and perforation is much more common in the pediatric population. So it occurs in up to 50% of children with appendicitis, occurs in 95% of appendicitis children under the age of 2. So the young ones really can get a peritonitis from this condition. Let's do a little anatomy and look at the Veriform Appendix, or just the appendix. You can see here's the classic drawing. It hangs off the cecum. This is actually the second most common position, but it doesn't always hang off like that, as we'll see. It arises with the cecum from midgut, so the gut tube. We just talked about that in the last lecture. I'm not sure if I got to that folding with you guys or not, but the midgut gives rise to the appendix somewhere between the 8th and 12th week of gestation. It is an intraperitoneal organ. That's a softball question, so you should know that is intraperitoneal. It is thought to, what does it do? We're not exactly sure what it does, but it has a lot of immune tissue in it. So it's thought to have some immune function for the region. It's also thought to contain a backup copy of your intestinal microbiota or the gut flora. We all have a nice balance. If you have a healthy digestive system, you have a nice balance in your intestines of good bugs versus bad bugs. If you get sick and have to take antibiotics, it will wipe out the good bugs and the bad bugs, and now you're going to be kind of a mess as these bugs kind of regrow and you have to repopulate your microbiota. Maybe more bad bugs will come back than good bugs, and you'll have all sorts of trouble. But the appendix is thought to keep a copy of your microbiota. And appendix, because the appendix is not super well supplied with blood vessels, the antibiotics usually don't kill off the gut flora inside the lumen of the appendix, and therefore after you stop antibiotics, that microbiota can come out of the appendix and spread throughout the intestine and kind of repopulate your gut flora to the proper proportions. The appendix has the same 4 layers as the esophagus, as the rectum, everything we've talked about. Mucosa, submucosa, muscularis propria, or externum, muscularis externa, that's the muscle layer, and serosa. They're not as well developed, but they're still there. It also contains a Meissner's plexus and an Arbach's plexus, but it's not well developed enough for peristalsis to occur in it. As I said, there's a lot of lymphatic nodules here. They're very similar to Prayer's patches. And so by the time you get old, these go away. In younger people and in kids, they're much more prevalent. And so these just prevent bugs from getting in here, because the appendix, you can drop bugs in there pretty easy and fecal material in there, and it can get stuck there. And so it's a high area for bacterial growth. And so the committee put all these lymph nodules in here in case the bugs get in through the intestinal wall. You got all these, they're like little lymph nodes, you can think of them as. They're filled with immune cells. So it's a good place to have those. The mucosa is made up of columnar epithelial cells, as usual. It does have its own mesocolon, so there's a mesoappendix here to go with that. So that's interesting. Remember, the small intestines have a mesentery, and the large intestines that are intraperitoneal also have a mesocolon. There's a transverse mesocolon and a sigmoid mesocolon and a rectal mesocolon. The ascending and descending are extraperitoneal colon, right? Ascending colon and the descending colon. The middle portion for sure is extraperitoneal, and there will be no type of connective tissue to that. What about the orientation? So the appendix could come off anywhere, any position from the cecum. So these are the most common. There's a rectocecal position, which is by far the most common. There's a pelvic, which is the second most common position. That's the one that we just showed you. There's a subcecal and periileal. Therefore, the clinical presentation of appendicitis can differ a little bit because it might be in a different place. So here's a good picture, kind of see-through. This one back here, that's the rectocecal region. That's behind the cecum, and that's the most common place for this to occur. It's posterior. Here's the pelvic one. That's the one that's always drawn, and there's the other ones we talked about. So I would definitely know rectal cecal is the most common. Pelvic is the second most common. 32% of the time it's like the books show. 64% of the time it's back there. Okay, McBurney's point. Now we're getting some lab overlap. So where's McBurney's point? It's 2 inches from a point going from the ASIS to the umbilicus. So it's right here. You have to watch this on boards because Robbins is a long-time board book. Bates is a long-time board book. They both say different things. Robbins says it's 1/3 of the way on the line going from the ASIS to the umbilicus. So they're both the same, about 2 inches or 1/3 of the way toward the umbilicus on that line going from the ASIS to the umbilicus. Right, there's another picture of it. And who cares about McBurney's point? Classically, patients with appendicitis have pain and tenderness at this location. In fact, if you do rebound tenderness there's the McBurney sign is indicative. Rebound tenderness at McBurney's point is McBurney's sign. That's indicative of appendicitis. But despite the classic teachings, the appendix, again, is not physically located even close to McBurney's point. So all those locations are not even close to it. So it's not within 5 centimeters of McBurney's point in 50% of the patients. So what does that mean? It means it's referring pain. McBurney's point is a common referral site. Pathogenicity. We're not 100% sure. Despite 100 years of study, there's no single explanation that can explain all cases of appendicitis. In other words, we still don't completely understand it. The classic theory is the one I gave you in lab, where you get an obstruction, usually fecal material, maybe packed with sesame seeds or some type of seeds, gets packed in the lumen of the appendix, and it stops blood from leaving. It blocks the venous blood flow. Venous blood flow expands the walls of the appendix to the point now it crushes the arteries. Once the arteries are crushed, the appendix can get ischemic. Once it gets ischemic, it can die and become gangrenous. In addition to that, there's bugs inside here that are trapped, and now they're not being flushed out as usual. So the bugs are growing, invading the appendix wall, and sparking another inflammation. So kind of a double whammy. You have ischemic tissue going on here, and now you have a bug infection, which has sparked an infection, and it's not a very good infection because the blood vessels are messed up. So it's very easy for you to poke a hole or get what's called a perforation of this appendix and have all the pus spill out into the peritoneal cavity. Right? Everything I just said. Right? And there's an appendix that is all swollen up and black, gangrenous looking. And yeah, and once you get, if this ruptures and lets that pus and inflammatory juice drain into the peritoneal cavity, you can get peritonitis, which can jump into septicemia and cause death real quickly. There's a normal appendix right there. Mesoappendix you can see attached to it. Nice vascular pattern. Clinical presentation. It's very important to catch this before it perforates. People die when it perforates. So you got to be on the lookout for the classic signs. And unfortunately, this classic presentation is about in 55% of people affected. So it can present as back pain. There's many different presentations. But most of the time, it presents like this. The patient history is key. So they get a poorly localized pain around the umbilicus. And somewhere, maybe in the epigastric region, it's kind of moving around. It's not localized. It's not severe yet. They typically get a downward urge, which I don't think I've told you that before. So there's a note card. That's an AKA for tenesmus. They get a sense that they have to defecate, and they sit on the toilet. They think it's something to do with defecation, and they can't defecate. A diarrhea may be seen early on, but that's usually not a big symptom. It's just that kind of vague pain around the umbilicus and at the in the xiphoid region. Then about in 4 to 12 hours, the second classic symptoms pop up. So an average of about 8 hours later. Now they start to become nauseated. You could throw up. Emesis could occur, but could be. It's not the major symptom though. They don't want to eat. They're sick now. They don't want to eat. They could vomit. They could not, but they're nauseated. They may feel chills and fever at this point. And then the third wave of symptoms strikes at about 18 hours. And now they have real abdominal pain. But here's the key, is the same thing I said in lab, that pain has shifted. And it shifted from the umbilicus right to the right lower quadrant. And that shift is the strongest indication for the diagnosis of appendicitis. This shifting phenomenon is seen in over 80% of patients with appendicitis. All the students I've seen who have had this and talked to, they say, yep, that's exactly what happened to me, and they go into the ER once that shift occurs. And it's thought that shift is thought to occur when the peritoneum of the appendix becomes inflamed. So the appendix is so severely inflamed it spills over in the peritoneum, or the appendix has perforated and pus is oozing out of it, and you're starting to get a general peritonitis. Clinical presentation, they have rigidity, we've talked about in the lab. Involuntary muscle spasm could be present. Rebound tenderness may be present at this point. Remember, that's called a McBurney's sign, is rebound tenderness right over the appendix. I'm going to add that to slide 93. McBurney's sign is rebound tenderness right over the appendix. The temperature is typically elevated but not crazy high at this point. Deep palpation anywhere in the right lower quadrant, indicative of appendicitis. Involuntary muscle guarding, appendicitis. This is what I want to get to. So Rolfsing sign we talked about in lab. These are the same lab slides, so it should be easy for you. It's deeply pushing into the left lower quadrant, and holding recreates pain in the right lower quadrant. This is not a rebound test, remember. Okay. This is a very strong sign that they have appendicitis and they should go to the emergency room. McBurney's sign, that's what I told you. I guess I don't have to add it now. That's a rebound tenderness at McBurney's point. All right, so push the fingers down at McBurney's point and quickly release them. If they have horrible pain, they have appendicitis. They might even have peritonitis at that point. Blumber's sign, that is a general test for peritonitis. It can be used for peritonitis of the appendix as well. You have to do a rebound test, but you don't want to do it over the exact area of pain. You want to go 6 to 10 inches away from the site of pain and do a rebound test. Push down and then quickly withdraw your fingers. And if that causes pain at the pain site, it's positive for appendicitis. It can be used for appendix, gallbladder, or suspected small bowel obstructions. Psoas test, we said. Psoas can stick to the inflamed appendix. So if you flex the patient's hip, that's positive. Patient can be supine on the table. Let's go here, and just have them flex their hip against your resistance and see if that hurts. Probably better way is to lay them on their side and just extend their hip, which will stretch the psoas. And if the inflamed gallbladder is stuck, it's going to cause severe pain. All right, that's definitely it. We won't get into diverticulitis or diverticulosis. All right, good luck on the test.